I want to get to the floor. Godfrey, I know you wanted to jump in.
Well, Steph more or less has said the last thing. I wanted to actually ask Helen what type of guidance she would find most useful. Because would she now say, okay, we're coming out of this conference, WHO reviews the evidence and finds, well, really, this is great stuff. So the guidance to countries is, yes, treatment for prevention works, do it. Or would you find it more useful to say, if guidance says, well, there's treatment for prevention which seems to be most efficacious in certain and possibly can be best applied in certain situations. There's maybe evidence from PrEP that seems to be most effective and efficacious and effective in other situations. Or what type of guidance would you expect to inform your prioritization decisions, or would you expect guidance that basically reassures you that this is the right thing to do?
I'll let you answer that because it's a good question.
Yeah. So I think that with something, I mean, WHO, for example, on PMT-CT was extremely quick about going to the field and saying, this is the evidence, it works, get out there and do it. I think that where you have an overwhelming piece of evidence, for example, like 052, where you're actually building on what people are trying to do anyway, where you can reinforce that. I think that that's the kind of thing where I think it would be very useful to say to countries, listen, get out there and do this and see if, aim to try and push up your starting levels for treatment. That kind of thing I think would be very useful. The separate thing from this would be to try and give some sort of weight to the evidence. It's discordant couples. I mean, one of my concerns yesterday with the panel was that it was all about, slapping everyone on the back and saying, jolly good, let's wrap up and go home now. We've kind of cracked it. And we missed the nuances of this. Because while 052 was compelling, Partners PrEP was compelling, but for discordant couples. And then, as we said, we've got IPREX, which was compelling in a particular population. And then you've got CDC, but we didn't mention FemPrep. So there are nuances that I think that we have not got into, and we need to explain that to the field, because otherwise everyone's going to think that everything is equal. It's treatment for prevention, it's all got equal weight, we should try and do everything. And I think that WHO needs to give some interpretation to this data at this point to say, this is what we definitely know, this is what we feel we should get more on. And these are some of the options already that countries could consider, such as MSM services. But you'd have to think that you're putting in a new service in many places.
Great. You can clap. Definitely want to go to the floor, please. Yes.
Well, Scott Burris from Philadelphia, Temple University. Stefan had a great answer. Stefano had a great answer on the hard question of money. So I'll go back to the easy one of policy. And I want to put it to you really as representatives of us, because it seems to me we don't do enough. We've all known for 25 years that the legal oppression of people because of the drugs they use, the sex they have, whether they charge for sex, how they got to be living in the place they're living, because of their gender, how they express their gender, that has crippled prevention. I think you had a slide on that, Mitchell. We still have lousy coverage of harm reduction programs. So we've got to do more about that, and all the great stuff here just accentuates that rather than takes it away. And it seems to me that although it's delicate to give countries advice or tell countries what to do, WHO, UNAIDS, UNDP are going to have a lot of opportunities in the next year to strengthen and make even less ambiguous their language about their recommendations about criminalization and so on. I mean, the high-level meeting was pretty dreadful when it comes to the discussion of harm reduction and drug use. So I think one thing we want to hear is, what are you guys going to do? And what's the UN system going to do, and the NGOs in that world, to make these recommendations even stronger? I also think that the research community could do a lot more. The fact is that the evidence base, even after 30 years, for how, we talk in general terms about stigma, but the evidence base for how oppression, especially legalized or organized oppression, influences people's risk behavior, their access to services, is still very weak. Still not enough research there. NIH does not fund enough of that kind of research. I don't think Gates does enough in what it does. In fact, I think everybody who does research, social and behavioral research certainly, but even to some degree people who are doing clinical trials could do a better job in trying to grapple with the questions of the mechanisms of these oppression effects, so that we could have a better evidence base about how they work and more ideas about how we could change it. So I'd like to hear, too, what research community people think they can do in the next year to help us get better results.
Great. Thank you so much. Let me start with Paul.
I may be excommunicated for this, but I don't think we've, following on what you said, I don't think we've scratched the surface as far as the implications of a new range of partners and some very different ways of addressing policies about drug use, sex workers, and men who have sex with men. And these tools could provide us with some extraordinary ways to approach these populations in ways where they're showing responsibility and all. I think one of the things that have come up in the last 2 days, for instance, and we're in Rome, so it's a good place to talk about it, how will the Catholic Church deal with these new technologies that don't necessarily stop fertility, which is a major issue for them? Will this be a new ally that we've not had before because we've got new tools? That may be hopelessly naive, and probably is, but it does, I think, indicate that there are opportunities about stigma, discrimination, criminalization that could come from these new tools that we haven't really started to think about.
Great. I wonder on the, Guthrie, do you want to pick up on that, or and then?
No, just very quickly on the issue of criminalization, punitive laws. We have just issued guidelines on MSM, men who have sex with men, that speak to that. Obviously, we need to now use them as an advocacy tool to help, and we're doing the same thing for sex workers, and already working on we already have an IDU document as well. The challenge, obviously, is, as I said, to really use this forcefully and in the negotiations with policymakers.
Tony or Steph, do you want to respond to the research side and funding and support for that?
Yeah, we know that now. I mean, we've known it for a long time. And actually at the NIH, we are partnering much more with the NIMH on not only obvious things like adherence issues, but issues of motivations and impact on things like stigma, etc. The studies are being designed and implemented, and they should be done. So I'll stop there, but it seems to me like it's like self-evident what the answer is. I mean, if you criminalize something, is that a bad thing? I think so. I'm not being facetious. I'm saying that we're going to do what you suggest. What you're saying is if you have a clinical study that says this has a negative impact, who are you going to impact that's going to listen to the clinical study that should have already known from just common decency that that's the wrong thing? So, I mean, it depends on how much investment you want to put into that. I think the people who go by that or guide their actions by believing that something is criminal I don't think you're going to convince them no matter what study you do. No, I'm sorry.
Because I'm a policy researcher and I study all those things that happen, and the stuff we've learned about how you work and intervene with drug users,
Yeah.
intervene with sex workers, that comes from understanding the risk environments that they're in, has been considerable, and it's led to policy change and practice change. So yeah, it's obvious.
No, I thought you would. No, wait. I'm sorry. I thought you were referring to policy changes on the part of governments who criminalize. Is that what you're talking about? Because that I don't think is going to change. If you talk about, maybe I didn't understand your question, that the stress that people are under because of stigma, how that influences their behavior. I totally agree with you in that, and we just finished a meeting with NIMH to say how important that was. I thought you were talking about policies of countries that criminalize things. So I misunderstood your question.
There's a lovely couple in the back who I don't think are just standing because they like to stand together. Renee.
Thank you. My name's Renee Ridson. I actually had a couple of comments. The first one, I want to harken back to Dr. Fauci's comment about a twofer. And I would actually challenge and say, if you consider the tuberculosis that is prevented and both disease and then transmission of tuberculosis, you may have a 3-fer or a 4-fer. So there are multiple benefits to treatment that are both to the patient and then also for public health. The other thing is, I think that with regard to what Helen is saying around prioritization, that this is an extremely important issue. There are finite resources, and that's sort of, that's it. And I think that there is going to have to be some thoughts about prioritization. This is going to be very, very complex. And I think that to expect each country to maybe come up on their own with prioritization may be a little bit of a daunting task, and some guidance around guidelines for prioritization might be very important. Just like we have guidelines of how you treat hypertension. You start with this drug, then you move to this drug, and then you move to this drug. Brian Williams did a lovely model for me a lovely model that he shared with me. And it's very interesting because when you take this model that has multiple different prevention interventions and scale up, say, male circumcision to 60%, then you really are kind of getting to a diminishing return for some of your other interventions, because you get much less bang for your buck. And some interactive models that could help countries in different situations where they could feed in country-specific information and get outputs along those lines would be very, very helpful in helping countries to think about prioritization and cost-effectiveness and relative cost-effectiveness of different interventions.
Great, thanks. Anyone want to comment on that? It's a terrific point. Lots of head nodding. Great. And anyone? Okay. Gus, I think you were up there.
I ended the last session by asking who the panel thought PrEP was for. We didn't really have time, and anyway, I think I have my own answer to that, which is that it's for people who are at maximal risk of HIV rather than just high risk, or imminent risk, to use a phrase from an IPREX poster in the early stages. So I think my feeling about PrEP is that its ideal use, apart from situations like women wishing to conceive, could be amongst people who are at that stage of their lives when they are at their very highest risk and their peak incidence. Great. Question is, how do you catch them in time? I don't, and I can't quite get my head around this. This is partially to do with the stigma and criminalization issue, because that's part of it, but that's not all of it. How do you get a young person who is at high risk of HIV to self-identify as such a person and to come forward to PrEP? Or equally, do you actually apply it on some kind of population level, in which case, how do you make the decision, how do you approach them, and how do you do your program? I mean, it makes things like instituting the HPV vaccine seem like a walk in the park in comparison. So that's the bit I can't quite get my head around, is how do we get to these people in time before they catch HIV and they have a lifetime of taking ARVs instead of a few years?
Helen and then Bob.
So I think that's an absolutely excellent question, and this is going to be one of the challenges. I mean, it goes with the earlier question about adolescence, because in our setting it would be we should be targeting young women. And the problem is this. We've got so many studies that show that people's self-identified risk and the HIV status are extremely poorly correlated. And we've got just lots of data, and we've got lots of data in young people that shows that. So that's a big problem, because they're not going to self-identify. And the second thing that we should consider for young women is that if you look at patterns of contraceptive use in societies where young women are, in Southern Africa, where a lot of young women are having children early and they're not married, the pregnancy comes first, the contraception comes after. So sexual activity in young people, we know from contraception. Yeah, exactly. So we have indeed got a problem, and we've never solved it for contraception. And now we're going to, and this is why we have to be very careful. We're going to take on PrEP for young women, and we don't really know what we're doing, and we don't know how to get it out there. So this is something that we're going to have to take several steps back. This is the kind of thing where we need implementation science, demonstration models to really start to understand that. This is not something I think that you can rush into the field with quickly, unlike the 052, where you can scale up and push quickly, and unlike circumcision, which is an easier thing to do in the context of health services.
Bob and then Mike.